All right, thank you, Becky. Good afternoon, everyone. I'm Emma Smythe from the Michigan Center for Rural Health. I want to thank you again for registering for the Telemedicine Billing for RHCs and CAHs webinar today. This will be an hour-long webinar from 1 p.m. to 2 p.m. The presentation has been available to you on the website of Michigan Center for Rural Health's website at www.mcrh.msu.edu under the RHC tab of our website, or you may open up the PowerPoint to follow along that I have sent to you prior to this webinar today. Completion of the program, you will be emailed an evaluation from myself. I will send this out directly following the webinar. You will have 2 weeks or by June 24th to complete this evaluation. Attendance has been monitored and will be monitored throughout the program. If you have more than one person viewing from your location, please email me a list of everyone attending upon receiving this, as I can add them to the roster. If you have difficulty connecting to the webinar today, you may listen to the audio component using your telephone and follow along with the PowerPoint. If you have any other questions, please don't hesitate to email me after this webinar at emma.smythe@hc.msu.edu. Again, I want to thank everyone for your participation. Now I would like to introduce you to our presenter for today, Jonathan Neufeld from Upper Midwest Telehealth Resource Center. I would like to thank him again for taking his time to present to us today. You may take it away, Jonathan. Thank you.
All right, thank you, Emma. Again, my name is Jonathan Neufeld. I'm Clinical Director at the Upper Midwest Telehealth Resource Center, and I am going to go ahead and share some slides here. So just one little kind of technical thing when we get started with the slides is that sometimes some people have, if you have your screen set up in a certain way, you might think that the slides are cut off, and what you need to do is maximize the slides in, or maximize your window, and then you can minimize it, pull it back down if you want. But there's a button in the upper right of the Zoom window that has maximize arrows out. You can also just double click in the Zoom window and it'll pull it up, and then it'll put the presentation full screen for you. And that's usually the best way for most people to handle it. If you have other if you're having other issues while I'm presenting, go ahead and chat to Becky, and she will be managing everything behind the scenes here. All right. These are the objectives that you may have seen already if you looked at the description of the webinar. We're going to talk about some of the research we have. Primarily, if you can keep your lines muted as much as you can. If you're on video, you can mute in your bottom left corner, or you can actually click on your own picture, right-click on your own picture, and you can access the mute. All right. We're also going to talk about the regulatory framework within which telehealth services happen. That's probably the main thing that helps you understand what you're actually billing for when you bill, and then we'll give you some details about billing. All right. So first, let me tell you just a little about who we are, the Upper Midwest Telehealth Resource Center. UMTRC is one of 14 telehealth resource centers across the country. 12 of them are regional. Those are the colors on the map. And then 2 of them in the bottom left corner there are national in scope, and those focus on technology and policy, respectively. So we have a couple of TRCs that can do a little bit deeper dive on those 2 particular issues to keep us all up to date. While the rest of us, the regional telehealth resource centers, try to focus on our region and getting out and visiting sites and doing on-site trainings and providing services, whatever we can, to help programs within our regions establish and evaluate and expand their telehealth programs. There's a national website at telehealthresourcecenters.org, and you can access that. And from there, you can see both our national webinar series that gets announced there, as well as links to all of the telehealth resource centers. All of them have materials online. They have example boilerplate contracts and boilerplate policies and procedures, various programs, stories about programs that have that are functioning, and you can feel free to use any of that material. That's all out on the web for free. And also, you can feel free to contact any of them if you want to follow up and say, hey, I saw this thing on your website. I'm wondering if you could put me in touch with that organization that's doing that. You can certainly do all of that. We're not jealous about each other's regions, and we share all the time. And you can either let us know, or you can contact other TRCs directly if you want something in particular from any of them. But we work together all the time. So please do feel free to make yourself follow up and get whatever access you need through the materials that we have. We do a lot of trainings and consultation. We use primarily a consultative model. These trainings are supposed to provide extra information, but as we've learned very quickly, every program is a little bit different. There's some common information that everybody can use, and a lot of times what organizations need is just a little bit of specific information to help them get over a hump or get through a rough spot, and then they're off and running. As you'll see, and I'll say this over and over during my presentation, telehealth is really not that different from what you're doing now. It really isn't, and I'm going to hope to prove it to you in this, or at least provide evidence of that in this webinar today. But if you understand a few basic sorts of concepts about how telehealth is regulated and how it's what it is as a legal entity or as a legal phenomenon, then most of the rest of the questions that come up, at least the regulatory questions, you can kind of work yourself through with some logic. But then other times, what is necessary in programs is to convince clinicians or convince administrators or board members, and oftentimes bringing in somebody like us with a lot of research or with a lot of experience, a lot of connections, or other programs that we can contact on your behalf. Sometimes that's what's necessary to get you over the hump. So definitely follow up with us, contact us if you need something like that, or if you think something like that can help. We also keep in touch with current policy developments, of which there are quite a few these days, and I'm going to talk about a few of them in a few minutes. Okay, so let's talk about telehealth and just kind of set the framework within which telehealth functions. The basic reimbursement model for telehealth is what this diagram shows. There is on the left side a rural, for Medicare at least, it has to be rural, but there is an originating site. That's the site, that's the legal entity, the clinic, the office, the hospital, some clinical entity actually, that where the patient physically is during the consult. And then there's the specialist site or the distance site. The technical term is the distance site. It doesn't have to be a specialist. It could be primary care. It doesn't matter what sort of a clinician is at the distance site, but the distance site is where the clinician is. And there's a little bit of confusion here. So right off the bat, there's something you need to be aware of. The language, the regulatory language, and we're basing this on Medicare, which is kind of the oldest regulatory language we have for telemedicine, goes back to 1996. But the language is distance site, and that is defined as the physical location of the provider, the clinical provider at the time of the consult. But it's actually not the physical location, because all of the regulations around distance site refer to the billing entity. And as you might know, a doctor might be in one location, but they bill out of a central location. They might be at a satellite clinic, but all the billing comes out of the home clinic. They might be, on one side of the campus, but the billing address is actually the other side of the campus. There's all kinds of variations of this, but the basic underlying fact is that the billing entity has a location, and the distance site, technically, from a billing perspective and a regulatory perspective, is the location of the billing entity, and the provider is conceived of as sort of virtually existing within that billing entity, even if they're in a satellite location or operating out of their home office or a private office or whatever, but they're billing through an entity, and that's their location. Medicare and most state Medicaids and most commercial reimbursement, for that matter, follows a model where each of these sites and their individual sites, most of the time we're talking about individual sites, individual legal entities, different legal entities. Each one has the right to bill for part of a service, or actually a service, but it's two separate services. The originating site can bill an originating site fee. It has its own special code. Its code is Q3014. It's a HCPCS code for an originating site in telemedicine. It pays about $25. On the specialist side, the clinical provider bills their clinical CPT code, their standard code that they would bill for the service they were providing if they were providing it in person. And this is one of the first key points to understand, is that telemedicine services are the same services that you would do in person, but you're doing them at a distance. You bill the same code you would do in person, but you add a modifier, the GT modifier. So, for example, a psychiatric evaluation, 90792 from a psychiatrist, first time they see a patient, or let's use an E&M code that some of you may be more familiar with, 99215. If that service were provided at a distance, it would be billed as a 99215 GT. The GT modifier indicates that it's done at a distance, okay? So that's the basic model of telemedicine billing. And now I'm going to talk a little bit now about some of the ways that telemedicine is implemented in sites, some of the business models around it, because each of them tweaks it a little bit one way or another. And there's actually a second primary way that telemedicine is billed, and I'm going to talk about that in just a little bit. Because telemedicine is a big field, and I use the terms telemedicine, medicine, and telehealth pretty much interchangeably. Okay, if there's any distinction at all, I'm talking about billable services when I talk about telemedicine. Telehealth sometimes is a larger domain that may include services that aren't necessarily billable, but they are health-related services. Okay. But when I say telemedicine, and usually when I say telehealth also, the implication here, we're talking about billable services, things you can bill for. If you're not going to bill for it, then it doesn't really matter what the conditions of payment are, because you're not getting paid, right? So, and the other thing to recognize, and I'll make this point later, is that what you can or can't do in telemedicine is only regulated by licensure. The payers indicate what they will and won't pay for. And so that's our main concern here. As a practical matter, you don't want to do what you can't bill for. But there's a whole lot more that we can do clinically via telemedicine that we can't get paid for yet. Although that's changing quickly, and Michigan is a good state for it. All right, back to the slides here. There are three basic domains that telehealth falls into. It's a big world. Telehealth is a big world, and so it's helpful sometimes to break it down. We find it helpful to break it down. Hospitals and specialty services are types of things like tele-ICU, telehospitalists, even telecardiology, teleneurology. When you're moving a specialist from a specialty center or a multi-specialty group or a academic medical center out to some rural area, you're providing services. Maybe you have a number of different specialists, and you're providing services out to an underserved area or a rural area where they need those services. And that was the first type of telemedicine. It used to be the only type of telemedicine that was going on. But in the last few years, there's been such a push toward primary care and patient-centered medical homes. The ACA, the Affordable Care Act, Obamacare, if you will, emphasizes primary care a lot. There's been a whole lot of kind of pendulum swinging toward primary care these last few years. And so that, along with a lot of changes in technology, have given rise to a different sort of perspective on telehealth, where you will sometimes have primary care entities that are bringing in services from multiple other sites. And so to them, telemedicine looks like they're the hub, they're the center of it. The primary care site is the center, and they might get specialists, neurologists from here and psychiatrists from there and cardiologists from over there, and then contract with a monitoring company. And so all of that might be happening out of a primary care entity, and that's a slightly different model than the original telespecialist model. And then there's the whole world of transitions and monitoring. What you could, from a technological perspective, is called remote patient monitoring, various types of monitoring systems that the patient might use at home or might use in some kind of other residential facility. But the basic idea there is that we're managing transitions or getting services out to where the patient is to avoid an inpatient stay, or to make a discharge stick, make the patient function better at home so they don't have to come in, or function better in nursing care so they don't have to come back to inpatient, or function better at home so they don't have to go to nursing care, or whatever. We're managing transitions. If by transitions you recognize too that sometimes that means we're trying to avoid a transition or avoid an admission of some kind. So that whole world of monitoring exists, and there's a whole lot going on in that world. It's also distinguished from other types of telehealth because it is asynchronous in the sense that the patient might do a bunch of things that the provider doesn't know about until they go and look in the chart. In other words, the doctor or a nurse or whoever does not have to be sitting there with the patient at the time they're taking their blood pressure. They just get a bunch of information and they can review that later. So it doesn't have to happen at the same time. Also, a lot of these telehealth services are not billable on a per service basis. They're just, a month at a time, or sometimes there isn't any billing at all, any reimbursement at all. Hospitals and organizations do it just as a quality issue or to reduce unnecessary rehospitalizations or even excess hospitalizations within a certain time period, a month or whatever, readmissions that what they would be penalized for. And the whole point of those three different domains is that telehealth has a slightly different value proposition within each of those domains, and the kinds of technologies, the kinds of services that you're implementing within each of those domains can vary. This is just a kind of a graphical representation of the difference between domain one, the classical hub and spoke model, where the hub has all the providers and the spoke sites around the rim are seen as where the patients are, and so the doctor sees the patient at the spoke site, and all of the telemedicine, the locus of the telemedicine activity is the hub site, the specialty site. That has been flipped in recent years quite often, and the patient site, the clinic, the primary care clinic or whatever remote facility, sometimes it's a critical access hospital or an RHC or provider-based clinic or whatever. But where the patients are starts to be the locus of services, and those services are brought in from lots of other locations. And so you end up with a situation where clinics, doctors' offices, hospitals, community mental health centers, any of these organizations could contract with any provider anywhere. And it looks much more like a peer-to-peer model than a hub-spoke model per se. Each locus of service kind of looks like its own hub, of course, and any place that has multiple providers serving multiple areas looks like a hub as well. But everybody's a hub, everybody's a spoke, kind of an idea, and that's sort of what's happening in a lot of telemedicine. So that being understood, and you remember back to the original kind of CMS Medicare model of the patient site or the originating site and the distance site, that still obtains, that distinction is still important to remember in billing, even though it may look like a peer-to-peer arrangement. There still is, the patient is still at one organization, the originating site, and the clinician is still at another, the distance site, and that does drive billing regardless of these other kinds of situations that models that might exist for telemedicine. And the whole idea of this flipping the hub and spoke model is that it puts the rural entity in charge. And this is why I wanted to bring it up here to underscore that for rural health clinics and critical access hospitals. You're not so much at the mercy of the academic medical center or the big urban medical center for your specialties anymore, at least not any one. You could go to an independent group for cardiology services, or another independent group for neurology, or maybe a multi-specialty group for a number of things. You could hire a psychiatrist in the next county, or a clinical psychologist from somewhere else, or social workers from somewhere else, whatever. You can bring in services from all over. This type of peer-to-peer telemedicine puts the clinic, the originating site, much more in the driver's seat than it ever was in the past. And this is kind of a new thing, and maybe it's not that of that much interest to organizations that are just now entering the telemedicine world, but it's a significant change that has made it possible and much more attractive for rural organizations to participate in telemedicine. There was a time when rural organizations would start, they would say, oh yeah, it's so great to have these specialty services. But then within a few months or a year, they would say, oh, we just can't sustain it. It's just too expensive for us. There was very little incentive and almost no compensation, reimbursement, such that they could sustain a telemedicine program from the rural site. Despite the fact that there was a whole lot of need, they just couldn't sustain programs because the originating site fee wasn't enough. And so this second model developed that I'm going to talk about a little bit later. The other thing to remember is that those services, when they're happening at your site, whether you're the originating site or the billing site, each site is billing for some component of that in the standard model. And so each site is recording that in their record. They have to justify what their billing was for, and they're responsible for the quality and the documentation for the services at their site. All right, so let's talk specifically about billing and reimbursement. First, you want to recognize that telemedicine exists within a number of different models. Sometimes organizations are going after new revenue. Sometimes they're going after reducing expense. Sometimes they're going after reducing or increasing efficiency or just access. Sometimes it's some other form of value, but there could be a number of different models, and it's important to be clear. Now, if you're the one doing the billing, maybe other people above your pay grade are making all those decisions, and that's fine. But it's important to recognize that the services, some services rely on billing for their value, and there actually are some telemedicine services that don't, that rely on either we're reducing travel expense, or we're reducing rehospitalizations, or we're doing something else that costs us money less. We're reducing some other kind of expense, and that's what justifies the program. I'm not going to talk about equipment at all today. I don't know. I just happen to have these slides in here, but just to throw out there that you can get started with a whole lot less money than you used to. Your minimum, something like this, a cart that we threw together for a previous grant, was about $5,000 per cart. Nowadays, we do similar types of systems for about $1,500 with $100 a year license. Desktop units like what I'm using now can get as low as $500. Basically, a computer and a webcam, and we do say an external webcam, because built-in webcams just aren't quite as good. But it's very, very inexpensive. I mean, an order of magnitude less expensive than it used to be. All right. So recognizing some of the regulatory barriers around telehealth, full medical licensure is required in Michigan to do telemedicine services. And this is true anywhere. Sometimes people ask questions about licensure and what about going across state lines, whatever. If you're within a state, your physicians have to be licensed in the state. It's pretty simple and straightforward. When you start to bring in clinicians from outside Michigan, they have to all be licensed in Michigan. Services, healthcare services, whether they're telemedicine or not, occur at the site of the patient. Doesn't matter where the doctor is, the services occur where the patient is. And that's where the doctor has to be licensed. They have to be licensed to provide services at the patient's location, whether that means licensure statewide or credentialing at a hospital, or to provide services in a hospital ED, or inpatient consults. They have to be credentialed at that hospital to do those inpatient consults. It's wherever the patient is where the physician has to be, or the clinician of any kind has to be fully licensed, credentialed, approved to operate at that location, to work at that location. Michigan, interestingly, has a reciprocity law, but and that's just kind of a detail, a curiosity at this point. But the internet prescribing thing, in case it comes up, I do want to throw it out, because there's this language that comes, that is kind of legacy language from the early 2000s, that internet prescribing is not something that's allowed in Michigan or anywhere else. And what is meant by internet prescribing is basically filling out a web form, filling out some sort of questionnaire, and the doctor prescribing medications based solely on the information in a questionnaire. So it doesn't really apply to telemedicine, even though we're using the internet for our services, but it's not the same thing that internet prescribing is referring to. Michigan, just to underscore it, requires a full license. They don't have a telemedicine certificate or a telemedicine license. It's a full Michigan license if you're a physician that wants to do telemedicine in Michigan. All right, so I'm going to talk about different payers. In a nutshell, Medicare pays for limited CPTs and only in rural areas. Medicaid has the same basic restrictions, or actually they pay the same as in person for Michigan Medicaid. There is a somewhat limited set of providers and formats, but we'll talk about that in a second. And then private payers have mandated reimbursement, so that any service that you would pay in person, they need to pay, they're mandated to pay via telemedicine. So you get a pretty good reimbursement framework in Michigan, pretty good environment for telemedicine in Michigan. This is the Medicare telemedicine fact sheet. This is the cover, what it looks like, and I've got a link to it later on. Every year this gets updated, and it's about 6 pages long, and it has everything you need to know about billing Medicare for telemedicine. It's very succinct, it's very straightforward, and it's fairly simple. Medicare is pretty easy. Now, it doesn't mean they're good or that it's the best reimbursement, but it's fairly straightforward. There's basically a page-long list of CPT codes. Here are all the CPT codes that Medicare covers, and it's a limited set of CPT codes, and they all need the GT modifier added. So this is what the clinician would bill for the service. The distant site clinician who's providing the service would bill these codes. They would add the GT modifier. Now, the other thing to recognize is that Medicare wants to limit the number of codes that they pay for telemedicine. And so the codes that they include tend to be generic codes, like the E&M codes right at the top there, the initial inpatient codes, the psych code, the general psych codes. Not a lot of specialized, highly specialized codes, but most basic outpatient clinical care is covered one way or another in these codes. So you can go through this list. You can see, if you have a neurologist who's doing stroke care, they want to bill an exotic code. You can say, if you can fit it into this initial inpatient code, we're good. Your exotic code, Medicare is not going to pay for that. So, so that's a concern when you're thinking about how to bill Medicare codes. All right. One other thing to be aware of is that Medicare does give some specific guidelines, requirements for the patient's location, the originating site. The originating site where the patient is has to be in a rural area. And this is the definition of the rural area. It's either a county, it's a rural county, either a non-metropolitan statistical area county, or a location in a metropolitan statistical area county, but in a high-numbered RUCA code, so one of the more rural census tracts with a RUCA code of 4 or above within an otherwise metropolitan county. It's a little complicated. You don't have to worry about that. There's a lookup tool, and fortunately, they've made this lookup tool. You can type in your address of your clinic or your doctor's office or wherever the patient is at the time and see if it's eligible for Medicare reimbursement or not. And if it is, in Medicare, if the patient is in that rural area, then both the originating site and the professional fee are both eligible to be paid. They're subject to the same copays and cost sharing that Medicare normally is. Everything, all parts of it, originating facility fee as well as the professional fee. A couple of things, there are a couple of new codes that Medicare added. I won't go into these in any detail, but basically the transitional care codes that you would, when you send a patient in follow-up after discharge, those codes now, the CPTs there are covered as of 2014. As of 2015, in addition to all the site codes that were on that original purple sheet, that now all these codes have been added. They're lesser used codes, but now pretty much the full range of site codes is included for Medicare. And then in primary care, the annual Medicare annual wellness visit and the Welcome to Medicare, the initial Medicare wellness visit, are both included. as well as a chronic care management code. Now, this is not a telehealth code. It doesn't get billed with a GT modifier. It doesn't. It's a very different code, but we talk about it sometimes just because it drives a lot of remote monitoring services. Basically, the CCM, Chronic Care Management Code, the 99490, is a code that's billable for certain patients with 2 or more chronic conditions when they're engaged in a specific care plan using a meaningful use certified or equivalent registry within an EHR, or some sort of system that's meaningful use certified to track patients with chronic diseases. So it doesn't have to necessarily be your EHR. It could be a module or even a standalone system that's certified to do this. And so the patient there has to be some sort of intervention with someone on the clinical team. It doesn't have to be a billing clinician, actually. Anyone on the clinical team with indirect supervision, 20 minutes within a month, and you can bill $42 for that intervention. So it's a very nice code for remote monitoring types of services, and it's going to drive. There's going to be a lot of uptake of this code as organizations use it to fund their remote monitoring programs. Whether the main goal of the program is to reduce unnecessary rehospitalizations, or to manage chronic diseases across a population, work on ACO quality measures and shared savings, or whatever other goals there are. This code now is available so that these types of services can provide direct reimbursement as well. It used to be a lot of organizations implemented these types of services without any reimbursement at all. So Medicare has added this to make that a little bit of a smoother transition, a little easier to implement. And even though 99490, like I said, is not a telehealth code, it doesn't need a GT modifier or any other modifier, it's just a standard medical code, it is going to drive a lot of expansion for telehealth. All right, Michigan Medicaid. Michigan Medicaid has a couple of specific limitations or indications, if you will. Consults and office visits are covered. So it's, again, the same basic list of outpatient services, individual psychotherapy, pharmacological management, end-stage renal disease services. Although there's a caveat with 1 in-person visit per month. I don't have to read these slides. You can follow them up or talk about, or review them afterwards if you'd like. The other thing that Michigan does, and this isn't a terribly restrictive list, but it does restrict the types of clinicians who can bill their regular clinical services as a telemedicine service, whether they can get reimbursed for doing what they're otherwise qualified to do at a distance. It's not terribly restrictive, like I say, but it is a restriction. Physicians, any physician, osteopath, podiatrist, nurse practitioners, mid-levels, physician assistants, which are billed under the supervising physician per usual. I think this is usual in Michigan. Nurse midwives also. Psychologists and social workers, services can be billed, but they're going to be working under community mental health service provider, an FQHC, tribal health clinic, or a direct payment, what's it called, a health plan. Anyway, there's the PIHP acronym. So they're either in a prepaid kind of a plan setting, their employer, in other words, bills for their services, they don't bill directly. And I think that's also per usual Medicaid policy in Michigan. And I cite it there if you need to look in the Medicaid provider manual. There are, just like Medicare, so Michigan Medicaid follows Medicare, shadows Medicare very closely, the same kind of structure of reimbursement. So there is an originating site facility fee as well for Michigan Medicaid, and this is the list of sites that can bill that originating sites facility fee. There are organizations that do telehealth to other sites, and they just say, well, their rationale is we can do the telehealth, we just can't bill the originating site facility fee. And that's a conversation that I'll leave to you and others in your organization. But these are the sites that are authorized to bill as an originating site, and that's that $24 code Q3014. Another couple of things just kind of to bring you up to date or keep us all up to date. In 2013, Michigan removed what they had before, which was a 50-mile rule. Clinician and patient needed to be 50 miles apart in order to use telemedicine. The thinking was that within 50 miles, you could just drive and do an in-person visit. But that was removed in 2013 in this bulletin. And then in 2013, also a lot of psychiatric codes were changed. If you're a biller, you know that. So Medicaid, Michigan Medicaid, of course, added those, transitioned those codes from the mental health, the previous mental health codes to the new ones, and so those are covered in telemedicine. This is the list of originating sites. I already gave that in the last slide, and this is just again highlighting that point that clinical nurse specialists, psychologists, and social workers can't bill directly for their services. They have to bill within a prepaid inpatient health plan. There it is. Community mental health service provider, FQHC, tribal health center. So they would, their employer would bill for them. This is the reimbursement table that probably all of you get every year, or you review it or have access to it anyway. And you can see up in the upper left corner the revenue code for telemedicine, which is 780, and the codes that Michigan Medicaid reimburses for, and again, kind of reiterating the use of the GT modifier for those codes, and then what they pay as a facility and non-facility rate. I talked about that, the elimination of the 50-mile rule. Also, commercial parity, what we call telehealth parity. Some of you may know what the mental health parity rules from a number of years ago. But now what we're calling commercial telehealth parity exists in 27 states. Michigan was somewhere around the 22nd or 23rd to pass this several years ago with these bills, 5408 and 5421, back in July 2012, so that all commercial health plans have to cover telemedicine the same as in-person visits. We also have a link here to the reimbursement amounts. You probably all have those available to you, but if you don't, you can certainly follow through there. So that's what I have about billing. I have given us, I realize that I've given a sort of a general overview to establish a kind of regulatory framework. There may be some specific questions that people want to follow up, and if so, we've left some time to do that. I hope that what I've been able to say, what I've been able to convince you of, is that billing for telemedicine services is really very much like billing for the regular services that you provide, with the addition of the modifier and a restricted code set. The other question, just to anticipate one question that may come up, if you're a PPS rate facility like an RHC or a critical access hospital that gets PPS rates, or a rural PPS hospital, can you bill your PPS rate for a telemedicine service? Here's the issue in a nutshell. If you ask Medicare at CMS, at the federal level, CMS folks will go to the regulations that were written back in 96 and 2000 for Medicare, and they will say that it doesn't mention anything about a PPS rate. In fact, it doesn't mention anything about FQHCs and RHCs, so they will say that those organizations cannot bill for telemedicine services at all. They can bill an originating site facility fee, usually, although it's taken, some states have had to specifically create a kind of a loophole so they can bill an originating site fee. But arrangements where the RHC, for example, let's say it's a rural health clinic, were to contract with a psychiatrist, and the psychiatrist would come in 4 hours a week to see patients virtually, and so the psychiatrist is an employee or a contracted provider with the clinic, just like other contracted providers in the clinic, and they're seeing clinic patients, they're seeing them on site at the clinic. Why shouldn't the clinic bill their PPS rate for that service that's being provided by their employee to their patients on site at their facility? I think that they should be able to. This is my personal opinion, that I think that's a valid arrangement. Many state Medicaid offices will say that's a valid arrangement. Indiana and Illinois specifically say that that's a valid arrangement. Michigan Medicaid does not say one way or the other. Michigan Medicaid gives you a certain set of codes that you can bill in a certain structure, and it follows Medicare's structure. And because Medicare doesn't talk about that kind of an arrangement, where the originating site would bill a PPS rate and have the provider coming in from off-site, because they don't talk about that, they're likely to say, no, that's not, you can't do that for Michigan Medicaid. So that's where that falls for Michigan, as far as we're aware. We have not heard otherwise. We hope that something like that could be possible, because it really is a good arrangement for rural health clinics and FQHCs and rural PPS hospitals, others that can bill a case rate or an encounter rate. So that's the one question I usually get. Now what I'll do is shut off the slides, and we can go back to the video, and we have time for questions. So you can, if you want to put them in the chat box, you can. If you want to go, if you're on the web, or if you're in the computer version, you can go down at the bottom of the screen. There's a participants button, and if you click on participants, you can find a raise hand button, and you can raise your hand, and you can do it that way. Or you can just unmute yourself and start talking, and we'll probably hear you. So, questions? I think, well, I can see that Becky muted everybody earlier, so if you're trying to ask a question and nobody's hearing you, which I'm not hearing anybody, you may have to unmute yourself, which you can do by going to the bottom left corner of your screen and finding the microphone icon and clicking on that, or you can right-click on your own picture, your own box that has your name in it, and then you'll get a menu, and you can unmute yourself there. Okay. Well, it looks like, oh, here we go. Can an originating, for this is Peter Marinoff saying, can an originating site utilize 340B? Can you specify what you mean by that, Peter? Utilize it for telehealth? I'm going to need a little more context to be able to address that.
Peter, I've unmuted you as well.
Oh, thank you so much. So if a patient visits with, let's say, a cardiologist here at the hospital, and the hospital's originating site, could then, and the physician prescribes something for that patient, could we then utilize 340B for that patient?
Yes, the medications are and how medications are supplied and provided is independent of telemedicine. In fact, the regulations and the reimbursement is purely around the professional fee and the originating site fee if it applies. So how the patient goes about filling that prescription, or how you fill it for them, or however, that's independent and operates under its own set of regulations that are separate from anything telehealth related. Does that address it?
Yes, thank you.
Okay, well, it looks like, okay, here's another one. For the originating site, you mentioned we can bill Q3014, and that's a Part B benefit. If the originating site is a hospital, do they have to bill Medicare Part B? Yes. That is a Part B payment. You can't bill it as a Part A payment. You don't have to bill it, but it is a Part B payment. So you have to bill it as such. And here's another one. Can you bill for injections at a telemedicine clinic? Both the administration and the medication. Again, I think this refers back. I think the issue is if the prescribing provider, the provider who's prescribing the injection is not on site. Obviously, if they were on site, you would bill the injections on site. Can they prescribe it and authorize that injection at a distance? And the answer is yes, they can. That, in fact, okay, so this gets into a little bit of a gray area, and here's what that gray area is. There are some services that telemedicine, the regulations around telemedicine, whether they're state or federal, they're conditions of payment actually, and the regulations around those conditions of payment for telemedicine purely focus on the professional fees that might be billed. It doesn't focus on what exactly the clinician is doing during that 99213 or 99214 or whatever it is they're billing. So, they authorize an injection, an immunization or some sort of injection or some sort of drug or whatever. They don't, the Medicaid, the telemedicine regulations are silent about any of that. Whatever is appropriate for the physician to order during a 99214, for example, 91213, for example, they can order. And they can do it whether they're at a distance or on site. Now there is, I should add one more caveat, and that is that the first appointment or establishing the patient relationships is sometimes, of course, a matter of contention. Your medical board will insist that the clinician have an adequate encounter as a first encounter to establish a patient relationship and also get whatever information they need is appropriate to provide the diagnosis and do the treatment. So in other words, the example that's always cited is if a patient comes in and complains of an earache, the doctor has to look in their ear. If they're just coming by video and they're describing their symptoms to their doctor, that's great, but it doesn't meet the standard of care for prescribing something for an earache. And medical boards kind of go around on that, and they say, well, maybe if you already know the patient really well, they've got a history of lots of earaches, they're bringing their child, hey, he's got an earache again, same as last time, can you prescribe again? Those are things that clinicians do all the time based on the relationship that they have. But as a first encounter with a clinician, the standard of care has to be met. And so this sort of principle would apply to other things like, ordering immunizations or injections or other types of services. They're not telemedicine services. You bill them just as if you would bill the injection normally, as long as the clinician is as long as that clinician is working in that clinic, which they are legally when they come in by telemedicine. As long as they're credentialed to work in that clinic, then they can order those drugs, order those injections, and the clinic can provide them. It's not a telemedicine injection. The injection is happening in person, live on site. So that one's not. So it's not. It's outside of the realm of telemedicine. This is another, just to point out, there is no such thing as a telemedicine clinic. Okay. There are services that can be provided at a distance, and that's the term we use for telemedicine. But those are just medical services. They're just regular medical services, but they're being provided at a distance. If you're not providing it at a distance, which by definition you can't do an injection by telemedicine at a distance, then it's not a telemedicine service. That would be just an on-site service. And the facility where the patient is, if they're not qualified to give an injection, then they shouldn't be giving an injection. The fact that there's a clinician on video doesn't make the originating site or the patient site qualified to give an injection or do any other kind of medical intervention if they're not already qualified to do that. All right.
And this is Becky. I'm going to go ahead and unmute everyone. So we've got several people that are on the phone, maybe having issues with unmuting themselves. So everyone is now unmuted. If there are any additional questions.
Would you bill, okay, here's another question that's coming in by the chat from Tiffany. Would you bill an originating facility fee on a UB as a hospital outpatient service? Yes.
No, it should be, yeah, no, it should be taken off.
Should be taken off the UB. Okay, clarify that for me. Who's helping me out here? Or was that not addressed to us?
I think that was a side conversation.
Okay. Okay, so, and as you may have recognized,
Yeah, you're right. It's really not a no-show, though. So let's, Kelly is down in.
Thank you.
Yeah, I got it.
All right. So here, the principle is that the way that your facility bills for outpatient Part B services is how you would bill for the originating site facility fee. So if you use method 2 billing, if you're using UB, and if that's how you do your outpatient services, then that's how you would do that. Does that, am I addressing that, Tiffany? I'm not a professional biller, and so you can follow up. I can give you the principles, and you can probably work out the logic around it. But I'm not a professional biller. Yes, thank you. Okay, good. Thanks, Tiffany. Any other questions? All right, I will reiterate then that we, the Telehealth Resource Center, the Upper Midwest Telehealth Resource Center, that's Becky and I basically, we are available to you. We can research questions even if if you feel like we haven't addressed something adequately or you have a follow-up question, please get in touch with us. Let us know if something's not clear, if we don't know what we're talking about, if there's something that doesn't make sense, follow up with us and let us know. We work much more one-on-one, individually, answering questions, researching questions, finding somebody who does know the answer if we don't. That's how we work, and we really want to hear from you. These general sessions are helpful, and we try and get a lot of information out there and mostly let you know that we exist, and if you're working with telemedicine providers and services, that you can come to us with questions and such. But that's the primary function here, is to get some information out there, introduce you to us, and we really do encourage you to get in touch with us. If you have any trouble finding us, finding our contact information, the folks at the Michigan Center for Rural Health can help you. They're partners of ours up in Michigan, and so definitely take advantage of that if you have questions or if there are other ways that we can help you develop, evaluate, extend, sustain your telehealth program. And I think that's it for us then. I will turn it back over to Emma, if you have any other questions, Emma, and you can take us out.
Thanks, Jonathan. That was an awesome presentation. Thank you again, Becky. I just want to remind everybody that I will be sending out an evaluation after today's webinar. And again, you will have 2 weeks or by June 24th to complete this evaluation via SurveyMonkey. And again, as Jonathan mentioned, if you have any other questions for myself here at the Michigan Center for Rural Health or for Jonathan or Becky at the Upper Midwest Telehealth Resource Center, you may email me at emma.smythe@hc.msu.edu, or you can give me a call at 517-355-7757. Thank you again, Jonathan. That was an awesome presentation.
You're welcome. Thanks, everybody.